to hit. Good grief.
All right. My topic was peripheral artery disease, which henceforth will be known as PAD. Just a couple things to realize while I'm talking about this before I go on. PAD is falls under the umbrella of cardiovascular disease. Cardiovascular disease itself is a very serious topic. It kills up to 16 million people per year, and it's actually the largest killer of people. If you combined, I think it was cancer, respiratory diseases, and diabetes, that still wouldn't even equal the 16 million people that die from cardiovascular disease. Peripheral artery disease, on the other hand, doesn't have as high rate of death because of the peripheral vasculature. And another stat was that it mostly affects people up to the ages 65 and over. But the reason, the other thing is the reason why peripheral artery disease is important is because it's highly associated with myocardial infarction and stroke. So PAD. So what is it? Basically, it's atherosclerosis of the peripheral vasculature, usually in the lower extremities. These are just some pictures of the most common areas that it occurs. You've got, in the top right, you got a picture of the tibial artery. In the bottom left, you got a picture of the abdominal artery going on right in there. And then the renal artery in the bottom right picture. And these are just the most common areas it occurs. So just remember that it's the peripheral vasculature and not any of the coronary arteries. So the etiology, again, it's atherosclerosis and the thrombotic processes associated with it. Basically, that's just blood clotting associated once, we're going to talk about atherosclerosis, but that's the blood clotting that happens after the plaque chips off. So it's a reduced blood flow to your lower extremities. And this is because the lumen in the blood vessels or the arteries become stenosed from plaque buildup. And it's important to understand that this is a lifelong process. It's not something that happens as just one, like a trauma, like a commotion cordis. Okay, it's built up over time. Okay, atherosclerosis. So this is basically the process that happens that leads to plaque buildup. There used to be, I guess, a more traditional view that it was just a deposit of cholesterol in the artery over time, and that cholesterol just built up. The modern view is that it's more of what they would consider an active process, and that's basically this whole snowball effect that we kind of talked about in class that happens. Basically, it can start as early as childhood, and it progresses through adulthood. First thing that really happens is that the endothelial lining gets damaged, and for some reasons unknown, the endothelial lining doesn't repair itself normally. So after that happens, platelet adhesion to the epithelial lining occurs, and then this just starts that snowball effect of calcium macrophage, or it's initially monocytes actually, and cholesterol, LDL, going through the artery. The LDL is important because basically that's what stimulates the release of cytokines, interleukins, specifically interleukin 6 and interleukin 1b, and this is really kind of those are the adhesion molecules that start the stickiness, right, in the lumen. So that's what starts as a fatty streak. Then it progresses to a fibrous plaque. It's also important to note that before it gets to the fibrous plaque, this is all reversible, and you could slow the whole process down through exercise. And what they say is the HDL actually slows it down significantly and reverses it. So like the good cholesterol actually reverses this process. But once it gets to the fibrous plaque stage, and that's what happens in like the third picture on the bottom right, I guess it starts to become more permanent. And in addition macrophages, all the calcium macrophages and LDL that accumulate, smooth muscle cells, all right, form the rigid fibrous cap, and that's what the collagen, elastin, and glycosaminoglycans are, and they form that rigid fibrous cap. So up to this point, this is where blood flow starts to get reduced, and it's not as, I don't know what the term to use, linked to death at this point. What happens is physical disruption of the lesion is the real problem. All right, that's what leads to what I said, the thrombotic events, and leads to a blood clot, and that's when it gets really dangerous. All right, so these are the risk factors associated with PAD. That's what I have. Age, I already said it. People age 65 and over, 20% of them are linked to PAD. Obesity, sedentary lifestyle, dyslipidemia, hypertension, characterized blood pressure over 140/90, smoking. That's important because that's one of the things that tobacco is actually what irritates the endothelial lining. So if you're smoking a lot, you've got a greater chance of damage to the lining, which will increase the chance of it not being able to be repaired properly. Hyperhomocysteemia, basically those are, it's an elevated level of homocysteines, and those are what actually degrade collagen and elastin, and diabetes also links or a risk factor for PAD. It's important to note that the comorbidities, so basically all of these increase your chances for PAD. Alright, so diagnosis. The main way to diagnose is the ABI index. That's your ankle brachial systolic pressure index. It's important to note that the systolic pressure is what they take, not the overall pressure or the diastolic. So this is a ratio. Basically, they take your systolic pressure in your ankle divided by your systolic pressure in your brachial artery, and these are the ratio that comes out. If it's between 1.0 and 1.29, it's considered normal. You're borderline at 0.91 to 0.1 or 1.0, and then from 0.41 to 0.9 is mild to moderate PAD. The symptoms, the most common symptom is pain in the leg, usually the calf, after exertion, so just walking. People sometimes they can't walk or they avoid walking, so it often goes unnoticed because they feel a little bit pain. They think it might be muscle or something, and they just avoid walking. And this leads to other things. So basically, it increases sedentary lifestyle and increases all the other risk factors like obesity and everything else. So some of the other symptoms other than calf pain are the legs and feet are cold. It doesn't just have to be the calf, it could be throughout the leg all the way up to the glutes. There's sores on the lower extremities, changes in the color of the legs and the toenails, and this is because there's that reduced blood flow to the lower extremities. And there's hair loss on the legs. Okay, and there's different stages of PAD. So stage 1 is asymptomatic, and that could be, you might have a ABI index of say 0.8, but you don't show any symptoms whatsoever. All right, you can walk forever and you'll never feel any calf pain. All right, then you've got the mild claudication. Claudication is just the pain. I didn't describe that, but that's what the term they use for the pain that people feel in their legs after walking or any physical exertion. Then there's stage 2B, moderate to severe. Stage 3 is ischemic rest pain, so you've got pain in that leg actually while at rest. And then stage 4 actually can lead to ulceration or gangrene, which is just basically death of muscle tissue. And that, once you get to stage 4, obviously gangrene is serious. It is serious, and that can lead to death if not treated. So treatment. The first is lifestyle modifications, and that's just the simplest of them. We try to educate all of the people with PAD on all the risk factors, so just increasing exercise, healthier eating, and quitting smoking, so that basically gets rid of the irritation. With the diet, they constantly refer to what's called as the DASH diet, which is low sodium, a lot of fruits, a lot of vegetables. And it's also important to make them understand that exercise isn't going to remove the plaque. It's really got to be a lifestyle change. So, what they might think is that, and in one case, there's my second case study, they think that if they exercise, for 2-3 months, the pain goes away, that they might be good. They're good to go. It has to be a lifestyle change. It can't just be something that you do for a short period of time. It doesn't just make that plaque buildup go away. So if you can't get rid of the leg pain through exercise or lifestyle modifications, they've got a lot of drugs, which are always good. You've got the first 3 are specifically for PAD. The clopidogrel, helps prevent a restenosis if they already had surgery on it, or it helps prevent a thrombotic event by slowing platelet accumulation in the area that's damaged. The warfarin and the hairpin also help prevent coagulation after the thrombotic event. The other drugs are basically just things that deal with all of those other risk factors like diabetes and hypertension. Surgical treatment. So if all of this doesn't work, then they progress to surgical treatment. You've got the angioplasty, which basically is that blowing a bubble in the area that opens up the reduced blood flow area. Then you've got, because what happens with the angioplasty is if you throw the balloon in there and blow it up, it can restenose. So sometimes they throw the stents in there. Now the atherectomy, that's basically, they throw this cool little thing in there and it like chisels away at the plaque. It's kind of like, I don't know if it's like a machine that chisels away at the plaque, and that helps reduce or increase blood flow. So I actually have a little video that shows all of these first 3. It doesn't show the bypass graft, which the bypass graft is just basically they built something to go around the artery, so blood can go around the artery.
Inject dye so that we can see under the x-ray guidance. And then we go and open up the artery with different kinds of miniaturized tools.
So this is the
One of them is called the
angioplasty.
angioplasty balloon. It's a balloon that goes and stretches open the artery, and it pushes the plaque to the side so that you can have normal blood flow through the area. Now sometimes that's not effective, and we'll leave in what's called a stent, which is a tubular metal mesh-like device, and that actually holds the artery open and pushes the plaque to the side. There's another type of procedure called atherectomy, where a device goes in and removes the plaque from the body. And it might do that by shaving it off, kind of like a cheese cutter, or a little tiny burr, a drill bit burr that spins so fast that it pulverizes the particles. Sometimes.
Never eating cheese again.
Yeah, like the cheese cutter one.
I just envisioned cottage cheese.
Alright, and now once the symptoms really start to worsen, like if you're going with talking about gangrene, amputation is an option. And that's what you'll see later on. It's only done if it's life-threatening. You can use cryo-amputation prior. It's important to note that with cryo-amputation, it's basically just to delay the initial amputation and delay all the pain that's associated early on. If you cryo-amputate, which is just freezing the limb, you still have to amputate the limb, okay? Then there's the physical amputation. So I have 2 case studies that are basically on 2 completely opposite ends of the spectrum. The first is this guy, Mr. C. He's a 70-year-old male. He's hypertensive. He had no cardiac conditions, which was important for what he was eventually prescribed. He had an ankle brachial index of 0.75, so that was considered moderate PAD. And he went to his doctor and he had pain walking. So the doctor referred him to a specialist. that's when they figured out he had the ABI of 0.75, and they basically just gave him a exercise program that he had to do at home. At home, a nurse visited him once per week. He was walking 5 times per week on the treadmill. What they prescribed him was basically you find the point of pain, and you just exercise below the point of pain, so below the intensity, below the speed. And your whole goal, so the goal was short-term goal of calf pain reduction and understanding all the risk factors. So they basically gave him that treadmill prescription, and they also educated him on nutrition. That was the main thing. They gave him like a whole DASH diet. So initially he could only walk 0.2 of a mile, and then he just had severe pain and had to sit. By the end of the 4 weeks, he was able to walk 1.3 miles. He also lost 11 pounds. I think a cool stat I read during the study was that it's possible to reduce your blood pressure by 20 millimoles or whatever it is. So he was able to reduce his blood pressure just by weight loss. And then obviously, yeah, his hypertension mildly decreased. Now, case study 2 was much more in depth because it was much more serious. Basically, we've got a 76-year-old male. He's got a long history of peripheral artery disease. He's already underwent a femoral tibial bypass graft. He's got a bunch of other diseases, hyperlipidemia, diabetes, and he's already on medications for for all of his diseases, including the PAD. All the stuff I already talked about, the warfarin, the clopidogrel, and aspirin. Prior to his acute bout of ischemia, he had an ABI of 0.44. He was still living a sedentary lifestyle, and he was still smoking, despite his extensive background with all these diseases, including PAD. He was still just ignoring all the risk factors. And it's also important to note that just 1 month prior to this, he didn't have any ischemic rest pain. So it was only during exercise that he had pain. And then in May of 2010, 1 month later, he started getting really cold in his leg, his left leg, yeah. And once he went to the doctor, they found out that it was pulseless, and they immediately referred him to an intensive care unit. So basically, it takes you along the whole time span. This occurs within 3 days of his time in the intensive care unit. They hit him with like a hairpin infusion, a plasma transfusion, and he was pretty normal that first day, but his condition only worsened as they went on. So they continued the hairpin day 2. At some point in day 2, he showed signs of intermittent confusion. Okay, and this was one of the signs of systematic sepsis, which basically was his body going through fighting a bacterial infection, and that's when it starts to get really serious. He also had a decreased urinary output, which suggests he might have had a decreased blood flow to one of his, I don't know, something that helps with urine. And then on day 3, all right, they tried an angioplasty, they tried another procedure, and none of them worked. And at this point, they realized that the leg was unsalvageable, and that's when they went for the physical amputation. Okay, he was just getting worse. Basically, his whole cognitive state was just worsening. First thing they did was actually one of those cryo amputations. So the picture there is his leg. This is actually the guy. His leg was put in a styrofoam box with dry ice, and that's basically what froze the leg. The cryo amputation actually helped a lot. He said he didn't feel any pain in the leg, obviously because it was frozen. And then 14 hours later, after the cryo amputation, they actually physically amputated it. They said you could actually go cryo amputated up to 6 weeks before it has to be physically amputated. They followed up with the guy. He had some complications. He had a surgery. I want to say maybe it was a month after the initial surgery. He had a stump with a problem. or no, because he still had a block after this. So he had a surgery for that, and then he was okay. Then he had problems with his stump, and he refused further surgery, and it was related to the prosthesis. So he basically just got rid of the prosthesis and had to use a wheelchair. And basically, as the writing of this case study, he was still on all the drugs, still living the, I guess, sedentary lifestyle, and still smoking. I read a couple other articles that I thought were important, or just something to note. The first was nutrients. Basically, when you think of PAD and basically diseases, a lot of people often think of just overweight people. It talked about obesity as a risk factor. One study with, I think it had 6,500 people done, did a nutrient recall, and it showed that the people with PAD, so up to 6,500, there was 520-ish with PAD. They averaged 1,700 calories, all right, throughout their daily intake. The people without PAD actually averaged 2,000 calories. So what you kind of often do is you kind of build like a causative relationship, and that it basically just said there needs to be caution when relating PAD with an obese person and their overall nutrient intake. The second study was actually more important, I think, or at least towards the future, and that's C-reactive protein, or CRP, as a marker. And basically this was something to test for the likelihood of future cardiovascular events. What happens is the cytokines that are released in that whole atherosclerosis process, I think I said it, interleukin 6 and interleukin 1b, stimulate the release of the CRP. Now, they use the CRP as a marker because the interleukin 6, because if one causes the other, why not just use the initial one? Basically, the cytokines are highly variable and the CRP is much more stable. So this could be a future good marker for an indication of possible PAD or other cardiovascular events. And they came up with just possible levels of the CRP to associate with the events. So basically, if you had between, or anything over 10 milligrams per liter was a high level of chronic inflammation. And this is just my ramblings. It's my turn to ramble on further than I already have. I already said the CRP thing, but the whole psychology behind this is kind of just bizarre to me. I don't understand it. I mean, because I just don't have that mindset. But you know, if you look at that case study where the guy lost his leg, I mean, we know what causes all these diseases. I mean, we know smoking is absolutely horrible for you. Yet people continue to smoke. You know, yet people continue to not exercise and continue to become overweight. I mean, we know why or what causes all these, but we still do it. So I think the psychology behind all of this is pretty important. I kind of talk about it at my gym all the time. The psychology just behind everything is really important, and if you can understand why they continue to use all these things that might lead to a premature death, then maybe you could change their mindset. All right, and that'll help decrease the likelihood of PAD. And that's pretty much it. Ignore the health insurance fitness facilities one, and this is my references.